being back with us. There is a small change in the scientific program. Next talk will be Dr. Frank Criado's talk about aneurysm myth debunked. Sacral aneurysms are inherently more dangerous. And then we will continue with the rest of the program. So Frank, you have the floor.
Okay, Victor, thank you. So I'll get started as soon as there we go. So essentially, over the next few minutes, I want to examine with you these three critical look at sacral aortic aneurysms. Number one, are they all ticking time bombs, like aneurysms in general? What about diameter measurements? How should we do this? It's not always clear morphologically. Should we include the normal aorta? And number three, do they rupture at a smaller diameter when compared with the more common fusiform type of aneurysms? So just a quick reminder that a sacral aneurysm is not to be confused with a pseudoaneurysm, and this is not always simple on imaging alone, but a pseudoaneurysm is one that is not contained by all the layers of the aortic wall. There is at least an area of the pseudoaneurysm where the adventitia alone remains before rupture occurs, and that's quite different from sacral aneurysms where there is aortic wall surrounding the sac. Sacral aneurysms are most frequent by far in the descending thoracic aorta. About some 20 or 30% of them are located there. Less frequently, 5% in the abdominal aorta, and even less frequently in the aortic arch and in the ascending aorta. We have been told, forever it seems, that sacral aortic aneurysms are prone to rupture even when small, so they should be repaired regardless of size. Okay, but just what is the evidence supporting such a dictum? There are a number of publications, and I've summarized about 4 of them right there over the last 10, 15 years, providing medium to low-level evidence that allow us to state that sacral aneurysms appear to have emergent and urgent repair more often than fusiform aneurysms and at a smaller diameter. They both have apparently similar growth rates, and the T-bar, specifically talking about the thoracic aorta outcomes, are very similar, but with a lower risk of spinal cord ischemia in the case of sacral aneurysm treatment. And that is not a surprise. Morphologically, and in its typical form, a sacral aneurysm looks just like that. This is a real-life example, of course, where the circumference of the aorta just adjacent to the aneurysm is essentially normal or intact. And this is an important observation because it means that we don't need to extend very much into that aorta to secure anchorage in a good seal. Here you have another example of the same assertion. And this is particularly important in the aortic arch. This is being rare. This is the most common form of aortic arch aneurysms, sacral aneurysms. They tend to be located in zone 3, encroaching into zone 2, sometimes even more proximally. In this case, as you can see, we had to go into zone 1 with deep branching of the left carotid and the left subclavian artery. Fusiform aneurysms, by definition, on the other hand, are far more extensive and require far more extensive repair. And so it's not surprising that the spinal cord ischemia risk would be higher in general than it is with it after treatment of sacral aneurysms. This has been a topic of my own personal interest for the past 13 or 15 years. This is a publication that appeared in the JEVT that I did in 2013, where there is far more clarity and more extensively in all of these concepts in case you are interested in reviewing further. Saccular aneurysms also occur infrequently, as we said, in the abdominal aorta. They don't usually have this configuration that you see on that particular example, and very often one has to go into the iliac arteries for endovascular repair, although the aneurysm does not involve the full segment of the infrarenal aorta. But in any case, these cases are relatively unusual. It has been found for a number of years now that there is indeed increased wall stress in the saccular aneurysm versus the fusiform aneurysms of the descending thoracic aorta, explaining perhaps that some of these aneurysms do tend to rupture at a smaller diameter. How to measure is an area of considerable interest, discussion, and even debate in some circles. Because, of course, we have several choices of what and how to measure. You can measure the base of the saccular aneurysm itself, the depth of the saccular aneurysm from the neck to its apex, or you can go all the way to the opposite normal aortic wall, the so-called transaortic measurement that, as a matter of fact, is the one that appears to be most correct and best in the vast majority of cases, if not all. Transaortic measurement, meaning that you go from the apex of the saccular aneurysm to the opposite normal aortic wall. And this is particularly true for the thoracic aorta. Better yet, of course, is to use, if available, 3D volumetric measurements. And even better than that, if you can obtain an EKG-gated CTA volumetric measurement. Aside from all this, individual morphology and architecture in general of the aorta and the pathology at hand is probably very important as well, adding to the relative unpredictability of saccular aneurysm behavior. As you can see in this case, that is particularly dramatic because of the size of this saccular aneurysm in the distal aortic arch that obviously implies a very large risk of rupture, possibly fatal, so one should treat this without delay. So, in the end, are they all ticking time bombs? And should we fix them all regardless of size? No. Diameter measurements, best to use transaortic diameter, as I said before. Do they rupture at a smaller diameter? Yes, they do. Thank you.